see the speaker today probably say good evening. You are welcome to the March edition of our regular webinar series. We've been holding this back to back for a couple of months, and actually have very interesting topic that we've dealt with over the last couple of months or even years. So today we have an interesting topic on food allergy. And so you are all welcome. Just to put some ground rules, please, if you are not speaking, please mute your mic. And if you have any question, you can chat in the chat box. And at the end of during the Q&A, if you want to ask the question, you will be asked to maybe raise your hand digitally, and then you can ask that question that you want to ask, and then you'll be asked to unmute. And I'm sure we're going to have a very interesting and engaging experience this afternoon. So I'll yield to President Dr. Letu to make his opening remarks. Over to you, Dr. Letu.
Thank you very much, Dr. Bishote. I also join you in welcoming all the participants to this webinar today. And I bring you greetings from Ibadan, where we're currently having the West African College of Physicians Faculty of Pediatrics examinations. Today, I'm sure we're going to learn quite a lot from Dr. Gupta, who is our external presenter. And I'm very certain that all of us at some point or the other will have managed a child with food allergy. So we're going to learn one or two new things concerning this condition. So without much ado, I want to welcome you all again and also say a big thank you to Dr. Gupta for presenting. Over to you, Dr. Bishote and Dr. Amala.
Thank you again, President Dr. Letu. So I'm going to yield to Dr. Amala, who is going to be the moderator for this session. You have the honor to introduce our guest speaker and then moderate session. So over to you, Amala, and please go for it. Thank you.
Muted. Sorry, I was muted. Good afternoon, everyone. Good afternoon, colleagues, and good afternoon, our senior colleagues. It's a privilege to moderate this meeting for this very interesting topic, the rational approach to food allergies. And it's also my privilege to introduce the speaker, Dr. Neeraj Gupta, and I'll just be reading his not so brief bio, but I had to abridge it, but I'll be introducing him. Dr. Neeraj Gupta is a foremost pediatrician with specializations in allergy, sleep medicine, and pediatric intensive care. He's the current director of the Diploma in Pediatric Allergy and Asthma program and the president of the Initiative for Sleep, Asthma, and Allergy Sciences. He is an associate professor at the Gangaram Institute of Postgraduate Medical Education in New Delhi, India. And that center is a World Allergy Organization designated Center of Excellence. He currently serves as the vice president of the Indian Academy of Pediatrics and is a member of several professional bodies. He's a fellow of the Indian Academy of Pediatrics, the Royal College of Pediatrics and Child Health in the UK. He has authored over 100 research papers and has written and co-authored about eight textbooks of allergy, including the comprehensive textbook of allergies. We're honored to have Dr. Neeraj Gupta in our midst. I would also say that I did my allergy training with Dr. Gupta, and he was one of those students in class that always had all the answers. And, you know, some of us that are trying to catch up will be looking at him like, please take it easy. We're trying to understand what is being said in the class. And he was the best graduating student of our allergy training program. So with your e-clap, can I see your clap emojis as we welcome Dr. Neeraj Gupta to handle the presentation on rational approach of food to food allergies. Dr. Gupta, you have the floor. You're welcome, sir. Good afternoon from Nigeria and good evening in India.
Thank you, Dr. Mala. Thank you for a nice introduction. And I am so thankful to you and for giving me the opportunity to speak today in front of your team, your organizing team. I am very thankful to the entire organizing team, including the president and all other dignitaries who are available here. And as you mentioned, that allergies are something which are, you can say, like very common problem, and now they are upcoming problem in all part of the world. So today we will be discussing a very important topic, which is food allergies. Uh, I am based in India, so I will be having some data from global and some data from India. So food allergies in office practice, and I will try to make the things as simple as possible. But I will be happy to take any questions after the talk. So I will be talking about different type of food allergies. Then there is common term which is intolerance. So is it same as that of allergy or is it different? So we'll be speaking about that, how to suspect food allergy and how to make a diagnosis, and then what to offer to the patient, what we can offer now and what in the future we can think about offering. So, if we talk about that, how common food allergies are, so the world over data is varied. If we just see that the developed world, especially in Australia, in UK, or in United States, the food allergies are now you can say like more prevalent with the tune up till approximately 10% also, whereas in developing countries, especially in India, and I'm sure at your part also, the food allergies are yet under recognized. They are still in the lower numbers. So we need to really understand that what is happening here. So we have got only a handful of studies from India till now, and these handful of studies are suggestive of very less prevalence. But it is all because of the type of the study, the limited sample size, and the limited understanding about the study that is happening. The most common food which we understand is milk protein allergy, and yet we don't understand this completely because we understand it's only one aspect, which is IgE mediated milk protein allergy. But when it comes to non IgE mediated component, then once again it get under recognized or many a times overdiagnosed or over suspected. So, what are the common food allergens? So, these are the 8 common food allergens which have been labeled or identified globally, especially from the developed world. Majority of the data is from the developed world. So, among which the most common one are the milk, egg, and then nuts, both peanuts as well as tree nuts. And then coming to fish, shellfish, soya, and wheat. And now, even the ninth allergen or the ninth food item that has also now been added to this list is called as sesame. So these are the food items which are more common. Majority of the time, they are responsible for 90-95% of the reactions which are attributed to food allergy. But if we just speak about other countries, like I am talking about India, so here there are certain other allergens which are dominating, like for an example, chickpea. We also see even brinjal, which is eggplant, many a times even coconut, and sometimes even banana also. So that actually highlights that whenever we are talking about 8 common food allergens or 9 common food allergens, so that might not be true in our country or probably your country, and we need to definitely have more regional data. Then only we can probably say that okay, this particular allergen or this particular profile is more relevant or more important for our reasons. Now, the question could be that why we are having different allergen profile, especially in the developing world or in India. It seems to be multifactorial. So one important factor is difference in the diet. If you just see that in the Western world versus the developing world, in the developing world, the diet is more, you can say, like in a form of a boiled form, more of a crude form. We in India are more legume consumers and we are predominantly having vegetarian diet. We are having more cultural practices in the sense like whenever a lady is pregnant, then at that particular time she is given or she is fed with a lot of you can say like food material, especially in the villages, in which that food material is having like carbohydrates, proteins, fats, along with different type of nuts and different type of other allergenic food items. So in a way, the baby is exposed to these particular food items much in advance, even before birth. So that is very important. So all because of the cultural practices this is happening. Then soon after birth, it is something like uh, exclusive breastfeeding, probably for the initial 6 months or 4 to 6 months, which is also helpful. 70% of India is still living in the rural areas, and in these rural areas, the hygienic conditions are not that great, and that actually led to more microbiota exposure, and which ultimately gives a protective effect on the allergic profile. So that is why probably the allergen sensitivity or the pattern is different in the developing world as compared to the Western world. And then the same food item, but different cooking practices, like for example, peanuts. In the Western world, more roasted peanuts are used, whereas in the developing world, like in our country, we are using more peanuts in the boiled form. So that also the boiled peanut is having lesser allergenicity as compared to the roasted peanut. So this is one study which was done by Professor Lack somewhere around 10 years back, and which is considered to be the landmark study, which has really revolutionized how we see food allergies. What this study says, so this is basically LEAP study. So LEAP study is basically telling us that if we introduce a particular allergenic food item early in the diet, then at that particular time, the body learns to tolerate it much better. In a case, if we delay the introduction, then at that time it becomes more allergenic. So, if I just want to keep a concept of initial 1,000 days of life, initial 1,000 days of life start from the conception of the baby. That means initial 9 months, 270 days of the baby in utero, and then after that, when the baby comes out, so initial 2 years of life. So that means from conception up till 2 years of life, they are very important. And the more the exposure of the allergenic items, more the exposure of the allergenic food items in this particular age group, the lesser the chances of developing allergies to them. So that is why this LEAP study was very important, and it has really highlighted that early introduction of peanuts significantly reduced the frequency of development of peanut allergy among children at high risk for development of allergies. But you may ask why we are talking about food allergies today, why food allergies are increasing. So if you ask me one clear reason, so there is no clear explanation. But yes, the whole world is moving from, you can say, like more hygiene, from the lesser hygiene to the more hygienic conditions. So, hygiene hypothesis says that as you are moving towards more hygienic conditions, then infectious disorders, infectious diseases reduces, and inflammatory disorders increase. That means allergies or other inflammatory disease could be rheumatological disorders, they increase. Similarly, if delayed introduction, suppose if the allergenic food item is not introduced in the early life, that means in the initial first 1 year or first 2 years, the child is not introduced an allergenic food item, could be nuts or could be egg or probably other food items, then at that particular time, the body doesn't learn how to behave, how to act when this particular allergen is introduced later on. So it is always better to introduce the allergenic food items timely. So the best window of opportunity is somewhere in between 6 months of age to somewhere around 12 months of age. So that is considered to be the best opportunity, not before 6 months, because exclusive breastfeeding is having its own advantages. So up till 6 months, exclusive breastfeeding. From 6 months onward, up till a maximum of 12 months, it is the right window of opportunity that the allergenic food items needs to be introduced one after other in sequence. And then food processing. So earlier we used to have more cruder variety of the foods. Now we are getting more processed foods. Processed foods could be like roasted foods, or we are getting now even more processing could be like in the form of pizzas and the burgers. So all these processing of the food ultimately creates more allergenicity than if the food is exposed to the skin. So it is considered that if food is exposed to the skin, then at that time it becomes more allergenic. Whereas if the food is taken through the mouth, then it becomes more tolerant. You might be wondering that why I'm asking about food is exposed to the skin. So there might be various ways. Like there are several moisturizers, emollients, even certain soaps or soothing agents, which might be food based, they might be milk based, they might be nut based. So at that particular time when you are applying, then at that time the skin is getting exposed to the food even before when the baby has started eating that particular food item in the diet. And this particular skin, when the skin is breached and the food item goes inside, it produces certain inflammation, and ultimately that starts the onset of atopic march. And atopic march is something like, to start with, it is like eczema or atopic dermatitis, which it starts, and later on it goes into full and florid atopic march or allergic march. And then coming to microbiota. So, more the heterogeneity of microbiota, there are lesser chances of allergy development. If there is a reduction in the good microbiota, then at that time the inflammatory disorders increases. And then generation by generation, epigenetic changes happen. This all because of lot of pollution which is happening, a lot of, I will say that, uh, environmental changes which are happening, and ultimately they are creating epigenetic changes, and they also uh, predisposes an individual towards developing allergies. So, few cases I will be discussing. So, this is the first case: 1 year old female child presented to us with a history of anaphylaxis after eating cake on a birthday. So, we understand that 1 year old previously well, no previous history, and now presented in the ER with history suggestive of anaphylaxis. And when we dig the history, then at that time we came to know that she went to a birthday party and ate some cake. So, what are the possibilities in that birthday party which might have happened? One will think about. So, it would be like probably she has taken some cake. So, it could be either milk, which is the culprit, or probably egg could be the culprit, or it might be certain sort of nuts which might be there in the cake. Or even sometimes you might also think about latex allergy, because latex is an essential ingredient of balloons. And in a birthday party, balloons are likely to be inflated there. So, in that particular environment, there might be some latex exposure, which might also create a problem. So, in this particular child, so these are the three culprit food items which we can think about. Now, how the food allergy or the food can, you can say, like, challenge the immune system. So there are ways. So the most common, easily understandable way is IgE mediated. So when IgE mediated pathway is triggered, then at that time a chemical called as histamine, which is released by the mast cell. And when it is released by the mast cell, then the different manifestations can happen. They can manifest in the form of urticaria, sudden started itching, or angioedema, which can happen. They can even go and produce some, you can say, like some laryngeal edema. It can also create some asthma type of manifestation, wheezing manifestation, bronchospasm, which can happen. It can also produce some gastrointestinal manifestations, could be intractable diarrhea, severe abdominal pain, crampy abdominal pain that can happen, or even the patient goes into a frank anaphylaxis leading to cardiovascular collapse. So these all can happen. So this is something which is IgE mediated food allergy. The typical nature of IgE mediated food allergy is that it is the time duration. That means a person who has consumed food, and within approximately 30 minutes to 2 hours, the person will start developing certain features. So this is IgE mediated food allergy, in which an allergen, the food allergen, is taken to the, you can say, like mast cell, which is already there attached. The bound IgE is there to the particular food item, and then this food item will attach to the bound IgE, ultimately triggers the reaction, releases the histamine, and then the reaction is produced. This particular reaction can be from mild to severe and life threatening. But if that particular food item is not following the classical IgE mediated pathway, and it is taking a non IgE mediated food allergy pathway, then at that particular time there could be manifestations which could be majority of the time localized to particular gastrointestinal tract. So non IgE mediated food allergy manifestations majority of the time they get localized to gastrointestinal tract only. So they can present with diarrhea, blood in the stool, some sort of eczema, sometimes failure to thrive, vomiting, tenesmus, abdominal cramps, constipation. So they can be there. This is non-IgE mediated food allergy, and the temporal relationship, the time duration usually is not as quick as there in IgE. That usually happens 4 hours or beyond. That can even happen even 24 hours later. So this is something which is non-IgE mediated. Majority of the manifestations are gastrointestinal related, but sometimes skin manifestation can happen, and Whereas in IG mediated, it is early in onset, they can be even fatal also, life threatening also, and the systemic manifestations, even in the respiratory system, cardiovascular system, laryngeal edema, all these things can happen. Even the skin can be involved. So the clinical presentation in IG mediated, I just told you about the clinical manifestations, whereas in the non-IG mediated, majority of the time it is the gastrointestinal tract which is there, but sometimes even the contact dermatitis or the skin manifestation can be there. And there are certain manifestations which can be common in IG and non-IG. And even the same particular food item can produce two different manifestations or a complex mix of them. That means in a single patient it can produce IG, in a second patient it can produce non-IG, in a third patient it can produce a mixture of IG and non-IG. So now the question comes that how you will investigate this particular child. So the most important thing for the investigation is it is the history, which is very important. We need to really go deep, dig into the history that what exactly happened. Like if a patient who come to us, then we need to be really like a detective, asking that from the attendant. Obviously, if a patient who is presented to us in anaphylaxis or in a real emergency, we have to first manage the child. There is no doubt about that. But once the child is stable, the patient is stable, we need to really dig deep into the history that what exactly happened. At what time the child went there, at what time the child ate something, what was that content, how much was that content, then when was the first reaction seen, what was the time gap between the food onset or the food intake versus the first reaction, and then how severe or mild this reaction was it intervened with some medication, that could be epinephrine injection, that could be some antihistamine, that could be some steroid, or so on. And then we have to take a past history, we have to take other atopic disorders, like whether the patient or the person is suffering from any other allergic problem. We have to take the environmental history, we have to also take the family history. So all these things, we need to really dig deep into the history like a detective, and then decide, okay, this particular child might be having some sort of allergy or allergic manifestation which is IgE mediated, and this IgE mediated, probably these could be the culprit items, these could be the food items, these could be the respiratory items or inhalant items, these could be the culprit items. So thereafter we need to decide about the testing. So there could be two different type of testing which could be available. One is in vivo testing, another is in vitro testing. When we are talking about in vivo testing, so the skin prick test is the most common one. And this in vivo testing is mainly detecting the bound IgE which is there on the mast cell. So mast cell is already circulating in the system, it is already having bound IgE on it, and whenever the food item or the arrow allergen comes in contact, and then at that particular time it gets directly attached to the IgE which is there on the mast cell, signal goes in the mast cell, degranulation happen, histamine releases, reaction happen. That means the skin test or the in vivo test, they are telling us about the status of the bound IgE. Whereas if we are talking about in vitro test, which are like the specific IgE, I will be discussing about them. So they will be taking us about the free IgE, which is freely circulating inside the system. Now coming to the skin prick test. So skin prick test we can do, but we need to really remember that if a patient who has underwent through anaphylaxis or a severe reaction, allergic reaction, we have to really wait for nearly 4 weeks' time. We need to give mast cell ample time to replenish themselves so that the histamine and the other chemical mediators can be replenished back in that 4 weeks' time, and then only we can perform the skin prick test. So by the skin prick test, we can actually detect that okay, what is happening. So what we are doing is that we are just taking a small amount of allergen, a small drop, putting it on the screen, and then piercing it through the lancet, and we are trying to, you can say, like detect whether there is a wheal and flare reaction which is happening in another 15 minutes or so, and at that particular time we can really detect about what is happening. But skin prick test positivity doesn't mean allergy. Skin prick test positivity will only tell hypersensitivity. If it is correlating with the clinical history, then at that time it becomes allergy. So there are two terms, hypersensitivity and allergy. Hypersensitivity is an immunological phenomenon. That means any test which is positive, whether it is a skin test or a blood test, if it is positive, that means the patient is hypersensitive. But this hypersensitivity need not to be clinically relevant. Whereas if the patient is giving a history that okay, this particular thing is coming in exposure and then the reaction is happening, now this becomes allergy. It is same like analogy like Mantoux test. So MEN2 test positivity doesn't mean tuberculosis. You require MEN2 test positive plus clinical symptoms, radiological features of tuberculosis, then only you will say it is tuberculosis. Otherwise, you will not say tuberculosis. Same way, it is allergy testing. Positive means hypersensitive. If allergy testing positive plus clinical consistency, then you will say it is clinical allergy. So that's why clinical history is most important. Now coming to the in vitro test. In vitro test is used, which is called a specific IgE. So many times we rely on specific IgE because if we have to perform testing sooner than 4 weeks, we cannot wait for 4 weeks time after anaphylaxis. We have to perform the testing earlier than we go with the specific IgE. If the patient is not having a healthy skin, the patient's skin is, you can say, like having a diffuse atopic dermatitis. If you cannot really stop antihistamines, then at that time you cannot do skin prick test. Then at that time you have to rely on the in vitro testing, which is a specific IgE. So what is specific IgE? Specific IgE, you are detecting against an individual allergen. Like for an example, if you are interested in detecting specific IgE against milk, then you can detect against milk, against peanut, against wheat, against dust mite, against cockroach. So a individual allergen, whether it is food allergen or respiratory allergen, you can actually detect the specific IgE by that. It will actually tell you about the free IgE which is there. So once again, if the test is positive, it will tell you the sensitization, and if this sensitization or the test positivity is matching with the clinical history, then it becomes allergy. So now the question is that how you will detect allergens, which allergen to test for. So it once again depends upon the history. So you need to take a deep history and then you will decide, okay, these could be the culprits. Like in the index case, in case one, this is a 1-year-old child in which the child has gone to a party. Previously he was well, ate some cake, and thereafter went into anaphylaxis. So what are the possibilities? The ingredients of the cake. And the cake ingredients are either the milk or the egg or the peanut. And sometimes even latex, which is there in the balloon, that exposure can also cause these things. So these are the culprit allergens. Suppose if in that party there was a history that there was a cat which was there or there was a dog which was there and the child has got exposure to that, then at that particular time they will also come into the picture, and at that time we have to select them also. So we need to really go into the history and then we will identify. Okay, and we usually say that there is no point in doing a blind panel, because if you are doing a blind panel of 10, 20, 50 allergens and many comes positive, but they might not be clinically relevant, and you will get confused, patient will get confused. So it is always better to dig deeper into the history, try to find out minimal number of allergens, probably 6, 7, or 8 allergens, that is sufficient enough, a maximum. And then you try to test them either with the skin test or with the blood test, and then try to match them with the history to reach to the diagnosis. So panel is having a limited value. Please do not do any, you can say like blind testing. That means you are unable to get anything and you have sent the patient for a blind panel testing. Please don't do that. It needs to be done. It needs to be done very targeted testing. That is important. So coming back to our case, 1-year-old girl, there was a history of anaphylaxis after eating cake on birthday, and 4 weeks later, this patient undergoes a skin prick test for egg. And if you just see here, so this was the whole egg to which this child was tested. This is the egg white and this is the egg yolk. So all three are coming positive. And whereas the controls, which are the negative control, which is saline, and the positive control, which is histamine, they are within the normal limits. That means this child seems to be giving a history that at 1 year of age, in a party, ate some cake, went into anaphylaxis, and now egg test is coming positive. That means the culprit here seems to be egg. So this seems to be very clear that this child is now suffering from egg allergy. So we took the history, we diagnosed the patient, and now we need to manage the patient. How we need to manage the patient? So first of all, obviously, if that particular food item is coming positive, we need to ask them to avoid. That means allergen avoidance. So allergen avoidance is very important. But suppose if you're asking them to avoid something, whether it is milk, whether it is egg, then you need to also substitute with something else. You need to tell that, okay, if you are unable to take this milk or this egg because of allergy, then at that time, what is the next thing? What is the different thing which will provide you similar type of protein or similar type of calories, but no same protein, so no allergy. So ultimately, you need to give them substitutes also. And then you also need to have a plan that when to reintroduce. So we also need to inform to the school that this type of life-threatening episodes can happen if by chance, by accident, the child shares a food with another colleague, another child who might not be aware about that. And at that particular time, the school must be ready with the anaphylaxis action plan and with the ready with the epinephrine or the EpiPen auto injectors. So these type of allergy action plans which are there and they are readily available and that need to be clearly mentioned with the child name, date of birth, identification things, and then in case of mild to moderate reaction, how to suspect, what to do. In case of severe reaction, probably anaphylaxis, how to suspect, what to do, and when to refer. This is important. Now, this slide is very important. With this slide is telling you actually about the natural history of food allergies. It is usually said that the first to come, so food, every food has its different story. The allergy to a particular food, first to come or early to come, early to go. That means if you just see that milk allergy or egg allergy with this blue line, they are more common in the initial 2 years of life or 3 years of life. And by the time the child reaches somewhere around toddler age group, somewhere around 4 years or 5 years of age group, 80% of the children, 80% of the children, they actually uh, start tolerating milk and egg. That means their milk and egg allergy goes away. Whereas the story is not similar for the peanuts. For the peanuts, it is only 20% start tolerating, but 80% still persist, and they persist for life. Even wheat allergy is also considered to be temporary in majority of the people, but tree nuts, majority of them, almost all of them, they stay for lifelong. So natural history of a particular food allergy, that is also very important in suspecting a particular child with food allergy. For an example, if a child, 5-year-old child, came to you with a history that he has got eczema since 6 months of age, versus a 5-year-old child comes to you with a history that he has started developing eczema from 3 years of age. So, in a child who started developing eczema from 6 months of age, I will definitely suspect milk. I will definitely suspect egg. Whereas in another child who started eczema at 3 years of age, I will probably not think milk and egg at that particular time. I will think about peanut. I will think about probably wheat, or I will also think about dust mite and even cockroaches also, which might be responsible for the symptoms. So history is the clue, and every particular allergen has their own story, which is important. So now, once you have advised a particular patient that okay, you have to avoid this particular food item, you have to take these substitutes, and then come the reintroduction after a certain time. So this reintroduction will depend upon the natural history of the food. Like we understand that milk and egg allergy, 80% of the time, the child start tolerating them by 3 years or 4 years onward. So what we will do that after around 3 years of age or 2.5 years of age, every 6 months we will reassess the child to whether he can tolerate or not. So depending upon that which test was positive earlier, we can either repeat the test or we can directly do some challenge test and then see, which is called as oral food challenge. If the child passes the challenge, then at that particular time we can continue reintroduction. Whereas the child fails, then we will wait and then 6 months later we will once again try to see. But remember that oral food challenges are something which are specialized procedures and which needs to be done in allergist office or probably in intensive care unit where every facility of resuscitation including anaphylaxis is available. So it has to be done with a qualified personnel who can manage all sort of serious reactions. So coming back to our child, so this particular child egg was avoided, and then after a certain time, the egg was reintroduced, but it seems that the egg allergy is still continuing. A child is not growing out of allergy. That means now the child is somewhere around 4 or 5 years of age. Still, the egg allergy is persisting. Now the parents are asking, can we do something? Like the child is not naturally growing out of it. Can we do something? Can we give some oral immunotherapy to this particular child? So the indication, what is the indication of oral immunotherapy and to which foods oral immunotherapy works? So we need to now understand what is oral immunotherapy. Oral immunotherapy is something in which we are introducing a temporary stage of tolerance in that particular child so that by accidental exposure, if the child accidentally, you can say, like comes in contact with that particular food item, so he will not develop the serious reaction. So oral immunotherapy, after oral immunotherapy, we are not giving a guarantee to that particular child of the parents that okay, this particular child can eat this food unlimited. No, Oral immunotherapy, that means we are introducing small amount of foods, minute quantity of foods, and gradually escalating up till the bite safe dose. Bite safe dose means that suppose if an accidental exposure to that particular food item happens in uncontrolled condition, so child's life will be saved. He will not be getting a serious reaction. This is important. So which foods? So people have tried for the many years world over. It's a peanut oral immunotherapy which has got FDA approval, and it is coming with the name of Palforgia. Now, this is a next generation allergy testing, which is called as component testing or component resolved diagnostic. This component testing is basically looking deep inside each allergen or their molecular profiling. Like, for example, our child who is having egg allergy. Now, in this egg also, if you just see the egg components, so there are certain components which are heat labile, there are certain components which are heat stable. So we need to really see that which particular type of component this particular child is allergic to. Suppose if this particular child comes out to be heat labile component allergic, then at that time you can actually give him eggs in a baked form. That means you can change the conformation of that particular component by heating the egg at a particular temperature for a particular duration. So because it was heat labile. On the other hand, if it is heat stable component, then this particular child will not tolerate egg in any form. So it can actually help you in prognostication. So that is important. Like I was mentioning, in the egg, this ovomucoid is basically heat stable. It is highly resistant to heat, whereas albumin is heat labile. So suppose if this child on component testing comes out to be ovalbumin sensitive or ovalbumin positive, then at that particular time you can actually give him baked egg. Whereas if it comes out to be ovomucoid, then at that particular time he will not tolerate any form of the egg in any situation. So there are certain advanced concepts which I will just enumerate about immunotherapy for food allergy. I have told you about oral immunotherapy, which is most widely used, which might be associated with some undesirable gastrointestinal side effects. So it has to be given by qualified allergist in office only, should not be practiced. Then there are certain other forms of immunotherapy for food allergies like subcutaneous immunotherapy, epicutaneous immunotherapy, and sublingual immunotherapy. But the best results till date are with oral immunotherapy only. And simultaneously, oral immunotherapy, you start with a smaller dose, gradually increase the dose. Ultimately, the aim is to make the patient bite safe. This is important. So you are not, you can say like completely curing the food allergies. You are just trying to make it bite safe. That means you need to start it in the minuscule dose, gradually escalate it up till a certain dose, and then that particular dose will be continued on a daily basis or frequent basis. If you stop that, then once again the food allergies will resurge, and ultimately the child will not be in the safe zone. So if you want to keep the child in the safe zone, you need to continue that particular dose of that particular food item on a daily basis so that the child can be prevented or the patient can be prevented from accidental exposure to serious reaction. So another case, a 4-month-old boy presented to us with 2 episodes of apnea after crying in last 1 week. There was a severe colic since birth which was there. It was excessive, inconsolable cry. Vomiting post feeds was there 2 to 3 times in a day, and the child was exclusively breastfed. There was no skin rash, stools were normal, there was no blood in the stool, there was no anaphylaxis, no respiratory allergies, no failure to thrive, growing well. That means a 2-month-old child, 4-month-old child with 2 episodes of apnea while crying, colic, and inconsolable cry, which is there. So, and we have to also see that there was some amount of vomiting which was there post feeds. So it doesn't seem to be classical IgE mediated food allergy. Either it is not allergy or it might be non-IgE mediated allergy. So let's see what is the difference between allergy versus intolerance. Allergy is usually immune mediated, whereas intolerance is usually non-immune mediated. Allergy is usually to a protein component. It is cow milk protein allergy, protein component, whereas intolerance is usually carbohydrate component, which is lactose. The symptoms of allergies could be rashes, itching. I told you that allergy, because it is Ig mediated, so it is having a systemic manifestation. So it could be skin, it could be nose, it could be chest, it could be GI, anything can be involved, and it can cause from minor till the anaphylaxis. Whereas intolerance is a majority of the time It is the gastrointestinal manifestations which happen. Allergy, true allergy, IgE mediated, the time period is from 30 minutes to 120 minutes. Whereas intolerance, it can happen in hours to days. So frequency of symptoms, allergies, that will happen always. That means patient is exposed to that particular food item 10 times. So 10 out of 10 times, he will develop symptoms. The symptoms could be mild or severe. That's a separate story. But he will develop symptoms each and every time. Whereas intolerance, small doses, he will tolerate, but larger doses, he will create problem. So sometimes he will say that I can tolerate, sometimes he will say that I cannot tolerate. So when I was speaking about non-IgE mediated food allergies, so majority of the time they are gastrointestinal manifestations that could be food protein induced enterocolitis syndrome, proctocolysis, enteropathy. So different type of non-IgE mediated adverse food reactions can happen. Not going in detail, but we need to really understand that the time duration here could be longer. It is not a typical 30 minutes to 2 hours like you see here. One day to one means like later basically it can happen, and then proctocolitis also it can happen later. Enteropathy it can happen later. So let's come to our case once again, case two, in which the pediatrician who was seeing the child, this 4-month-old child, kept a possibility of milk protein allergy, but the test was negative. At that time, he thought about that it could be non-IgE mediated, so he gave a trial of milk elimination diet from the mother as the child was exclusive breastfeeding. The symptoms became better, but since the intermittent episodes of colic and diarrhea persisted and eczema was there. So now the possibility was because the child has partially improved, so it could be possible that either the mother has accidentally taken some milk protein and ultimately the child has got partial improvement, or actually it was not milk protein allergy, it was some other diagnosis. So, how to approach a child with food allergy? So suppose if you have taken a good history, you have done certain investigations matched with the history, but you are unable to still reach to a diagnosis. Then at that time you can give a elimination diet, a diagnostic elimination diet for 2 to 4 weeks. If the child improves, then at that time you reintroduce, and if the symptoms come again, so it is diagnostic. Suppose if the child doesn't improve, or after improvement and reintroduction, if the symptoms doesn't come back, then at that particular time it was not allergy. So that is why many a times we are unable to make the diagnosis on the first visit. We need to really follow them, and then we can make the diagnosis in the follow-up visits. Regarding allergen avoidance, few words. We need to really understand, we need to really tell them that when you are asking them to avoid, then they need to understand that it is 100% avoidance, not 99% avoidance. That means when you are talking about milk avoidance, so that means milk and dairy products, all the dairy products. So that you need to tell them that what are these dairy products, and they need to avoid all of them. That is important. And many times even they need to really, you can say, like, read the ingredients also. Suppose in the ingredients it is written milk solids or contain milk, they need to really understand and read that ingredient also. And then substitutes are also important. For an example, if a person who is having milk protein allergy less than 6 month old, then at that time extensively hydrolyzed formula will be the key. After 6 months of age, if they can afford, it is extensively hydrolyzed formula. And sometimes we have to provide a plant-based milk, which is soya milk, if the child is not sensitized to that. And at that time, then we have to also involve a dietitian in between to prevent nutritional deficiencies, and we need to monitor that particular child for growth and development also. This is important. Natural course, I told you that majority of the time milk protein allergy, 80%, 90%, it gets resolved by 3 years of age. Usually IgE mediated resolves a little later, whereas non-IgE mediated allergy resolves faster. So when a patient or a child who is diagnosed with milk protein allergy, and now you are trying to, you can say, like, reintroduce milk, then at that time it is always better to reintroduce in the most safe form. Most safe form is the most heated form and minimal quantity. So most heated form, that means allergenicity is reducing. So more you heat, more you bake, allergenicity reduces, and minimal quantity. So this is a Indian milk ladder in which they have made this Indian milk ladder based upon step 1 to step 6. So step 1 is basically they are giving some sort of biscuits and so these are like the most baked product and minimal quantity. And gradually they are moving to the food items which are having less and less time of heating and more quantity of the crude milk. And ultimately they are reaching to the crude milk at the last step of the ladder. There are other ladders also from different countries, like this is Canadian milk ladder, depending upon the local food items which are available there. So similarly, in your country also, depending upon the local food items or the varieties which are available, a milk ladder can be formed. So this is one paper which our group has recently published, I think only 1 month back, in February only. This is Food Allergy in India, which is Delphi Consensus Statement by Indian Academy of Pediatrics, Allergy and Applied Immunology chapter. So our group has contributed this. So this is the first guideline, and I'm sure that majority of these principles will also apply to your country, your region also. So I will request you, this is available free to download. I can also share this paper with Dr. Amala, and she can share in your group. So you can read this paper, and this will solve your many of the queries which are there. So the key recommendations are that we have actually told that how to go for the diagnostic framework, which particular type of diagnostic test which needs to be done, which are the right patient, how to approach. Then which particular allergens needs to be targeted for, like we have included these allergens for India, then how to manage, and then how to give the nutritional support. We have also touched upon policy and public health initiatives, and we have also touched upon some preventives and specific therapies like oral immunotherapies in this paper. So you can definitely refer this patient this particular paper. So this is my last slide. Take home message: food allergy is an upcoming and under recognized problem in developing countries, with our country and your country both. Proper testing needs to be done to confirm the diagnosis, and it needs to be matched with the history. Dietary counseling is very important. Majority of the time, the people feel or the doctor feel that they are having allergy to this particular food item, and they are unnecessarily withdrawing that particular food item, which is probably not needed. And we need to definitely develop a food allergy service or a dedicated food allergy clinic where these particular patients can directly be referred and be managed by a dedicated team. That team will be having a dedicated allergist, nutritionist, or dietitian, and probably a biochemist also to help in, you can say, like getting certain allergy investigations. So with this, I would like to stop here, and I will just like to take 1 minute of yours. So this is one initiative which we have now started. This initiative is called as Initiative for Sleep, Asthma and Allergy Sciences. So the unique part of this initiative, this is a society. This is an initiative also called as ISAS. The unique part of this initiative is that this is not having any boundaries. That means any particular individual who is interested in learning, contributing, knowing more about allergies, asthma, or sleep, or airway biology. So they all can join us. So there is no boundaries for pediatricians or ENT or gastroenterologist or allergist or probably Indians or probably any other country. So there are no boundaries. We are boundaryless. This is a global body, and we invite all of you and all of your colleagues to join today. You can scan this barcode. I can send the link also to Dr. Amala, and she can share with you. So we are right now having a complimentary membership up till 15th April, and from 16th April onward, then the membership will become paid. So before that, you all will join, or you should join, and we will invite you for so many other academic activities. With this, I would like to stop here. Thank you once again for the nice opportunity.
Wow. Please, can we see those clap emojis for Dr. Gupta, Dr. Neeraj Gupta? This was very, very insightful. We asked him to make it as simple and as easy to understand as possible for clinicians who are non-allergists, who are not allergy specialists, because we need to know how to manage these children in our pediatric practices, and he did just that. So thank you so much, Dr. Neeraj, for a very lucid and very insightful presentation. Thank you for emphasizing the importance of history taking in managing these children. And, even apart from food allergies, other allergic conditions, history taking is very, very critical. And thank you again for re-emphasizing that. And also for telling us about early introduction of foods from 6 months. Because what we find in our practice is that most of us, once there's a family history of allergies, we don't even want to, try introducing and thereby reducing the likelihood of the child getting some immune tolerance. So thank you for emphasizing that and for differentiating between the IgE mediated and non-IgE mediated food allergies and food intolerance, for clearly differentiating between food allergies and food intolerance. I particularly like how you talked about the interpretation of food allergy tests and knowing when it is sensitization and how we should correlate before saying this child is allergic. Because what we find here is that we do the panel tests and then we say the child is allergic to everything on the panel. And then the children come back malnourished because as a developing country, we don't have so many food options for our children. So by the time a child is said to be allergic to milk, eggs, wheat, fish, the child literally has nothing else to eat, and then they become malnourished, and then it becomes another problem. And I also like that you mentioned nutritional and dietary support because we're all pediatricians here and we all know how important childhood nutrition is. I think at the heart of every pediatrician's practice is nutrition. So it was a good thing that you also brought it forward. And then other things like how to manage the treatments, the oral immunotherapy, and all that, and also for sharing your Indian experience with us. We're going to start sharing our Nigerian experiences. We should start documenting these things and, growing the allergy practice back home too. So thank you so much. The floor is open for questions and for comments. I have also posted the link to the Initiative for Sleep Asthma and Allergy Sciences in the chat box. So if you're interested, and I think you should be, Dr. Neeraj is very academic. I must say that again. And so since he took over the reins of the Indian Academy of Pediatrics and the Allergy Society of India, we have back-to-back academic sessions on that group. So I think it will be a good to join. The link is in the chat group. So I don't know if we have any questions. Any questions for Dr. Neeraj, you can raise your hand or unmute yourself and speak. Do we have any questions or any contributions? Okay, Dr. Neeraj, you talked about extensively hydrolyzed milk for babies with food allergies, cow's milk allergies. Can we also use just the partially hydrolyzed milk? We don't really, I think that is more readily available here for us, the partially hydrolyzed more than the extensively hydrolyzed milk. Can we also try the partially hydrolyzed milk for these children if we can't get the extensively hydrolyzed milk?
Thank you, Dr. Amala, for asking this question. So first of all, we need to really understand that whenever we are talking about milk protein allergy, so this cow milk protein allergy, cow itself word is a misnomer. So cow milk protein allergy is actually milk protein allergy or bovine milk protein allergy. So any other bovine milk, that could be buffalo. So cow and buffalo proteins, milk proteins, they are sharing 95% protein structure. That means there are 95% chances that if a person who is having cow milk protein allergy will also react to buffalo milk also. So that is why any other bovine milk need not to be given. The only relatively safer bovine milk is something like a mare milk. Mare milk is having somewhere around 10% or 8% of cross reactivity, but 0% cross reactivity is not there. So this is one point which I wanted to highlight. The second point is that whenever you are breaking down the milk protein into smaller peptides and ultimately to the amino acids. So the allergenicity reduce. So when the whole milk protein allergenicity, and if you are breaking it down to the partially hydrolyzed formulas, so this partially hydrolyzed formulas are still having that allergenicity. So ideally, they are not working. They will not work. And partially hydrolyzed is something like that, which is somewhere in between the extensively hydrolyzed versus the non-hydrolyzed formula. So then in between formula is not going to work, and it is not beneficial for a truly milk protein allergic patient. So ideally, either you start with the extensively hydrolyzed formula. Any of the guideline, if you see in the Western world, they all speak about extensively hydrolyzed formula. Or in India, like extensively hydrolyzed formula, either it is not available or very costly. Then at that particular time, we offer them soya milk. So soya milk is basically soya bean, which is plant-based milk. So the protein itself is very different. So bovine milk protein versus plant-based milk protein. So there is a structural homology between the two, nearly 15% of the cases, 15% of the cases. So at that particular time, 15% of the patient might not tolerate, but 85% of the patient usually tolerate soya milk if they are allergic to the bovine milk protein allergy. But answer to your question, partially hydrolyzed formula, no, it is either extensively hydrolyzed formula or no milk or soya milk or plant-based milk.
Right. Okay. Thank you. Thank you very much, Dr. Neeraj. Okay, we have a question in the chat box from Dr. Atiniko Wache. She asks, is there a correlation between food allergy in infants and developing inflammatory bowel disease in children?
So this is a very, I will say, a very thought-provoking question. Thank you for this question. And this actually is like something which is more research-oriented question. We need to really understand that allergy itself is an inflammatory type of a process in which the immunological system is creating some sort of inflammation. Now, whatever we understand out of this inflammatory pathway, the one pathway which we understand is IgE mediated, but there are several other pathways which are non-IgE mediated. So if it is IgE mediated pathway, usually it doesn't cause inflammatory bowel disease, but there are other non-IgE mediated pathways which can create FPIES, proctocolitis, and ultimately they might later on turn out to be IBD or inflammatory bowel disease, but still a lot of work needs to be done. So the answer to your question is probably yes, but we require more data to support this because it seems to be non-IgE mediated pathway, not a direct IgE mediated pathway.
Right. Okay. Thank you very much, Dr. Neeraj, for that response. Do we have any other questions or any contributions? Or he gave us a lot to think about.
Well, just to at least, just my hand was raised, but I don't think you saw my hand.
Oh, I'm
Just to
sorry, sir.
reinforce what is no, it's okay. Just to reinforce what Dr. Gupta said about cow's milk protein. I think even with soya milk, it's still better for you to do minimum or skin prick test, or if you can do immunocarbs I mentioned before you start giving soya milk, because like I said, some people cross react even that. So I would say that's the best option. There's no role, like I said, for partially hydrolyzed milk in cow's milk protein. The only thing I know the Kenyans, although I don't have the data now, and in Kenya, I know they also use goat meat and they use camel's milk, but I don't have data. They have some data about that for their milk allergy. But like he also mentioned, if you can do component testing, you can adapt the milk ladder to your case-by-case basis. Thank you for a very useful talk, Dr. Gupta. Thank you.
Thank you, sir. Thank you. So this is a very important point. Even the right point which you mentioned is about the goat milk. So there is a 40% cross reactivity which can happen. So 60% of the time, yes, goat milk can be tolerated in cow's milk protein allergy, but 40% chances it might not get tolerated. More safer will be mare milk. Somewhere in between is goat milk. Buffalo milk is definitely not safe. And I completely agree with your point, sir.
Okay, thank you, Dr. Gupta. There's a comment on the chat box that the link to register with ISAS is popping up an error message and it's saying page
I will
not
send you a
available.
fresh link. I will send you a fresh link.
Okay, all right. Thank you very much. I'll post that on the group. Okay,
Yeah.
so in the absence of any more questions or contributions, We want to say thank you, Dr. Gupta, for your time, for presenting to us. This is the Pediatricians in Private Practice in association with the Pediatric Association of Nigeria. So it's an honor and a privilege to have you with us. I would now yield the mic to Dr. Odushote, who is the head of the Allergy and Clinical Immunology Society of Nigeria. Dr. Odushote, sir, over to you. Thank you very much, Dr. Gupta. Thank you.
Thank you, Dr. Gupta, for the meeting, and thank you, Amala, for moderating. So I'll yield to Dr. Letu for his closing remark before we close the meeting. Dr. Letu, please.
Thank you so much.
Okay. Good afternoon again, all. Dr. Gupta, thank you. I know it's very late back in India, but you decided to stay up to talk to us, and we do not take it for granted. So, on behalf of the Guild, again, I say a big thank you, and we look forward to you having another talk with us very soon. And to all the other members of the Guild who've joined, both locally and internationally, I say a big thank you for joining and making sure that the participation topic. Thank you all. Bye. Over to you, Dr. Olusote.
So thank you, Dr. Lit, for final work and final thought. This just to announce that the recording of this will be available on our YouTube channel, so you can always go back to watch, and if there are questions, we'll be able to answer some of those questions as the time goes. I want to also thank Dr. Gupta for allowing us to actually put this material on our YouTube channel, and we really appreciate that kindness and generosity. We also said that the link will be shared for the sleep, allergy, and asthma for us to join. Remember, the freebies end on the 15th of April, if I'm not mistaken, and that can be, we can actually take advantage of that opportunity. So this also announced to you that next month, last Thursday month, we'll have a new session on this channel for a webinar. We're looking forward to having all of you again on this meeting. And if you have found today's meeting very useful, please invite your friends to come to join this meeting. And you can also go to the webinar, to the YouTube channel of the society, where you can actually look at the back story or back meeting that we had. And in the absence of any other question or answer or comments, this just say thank you for joining, and we hope to see you next month, last of the month, for another useful webinar. Thank you again, Dr. Gupta, for joining us, and God bless.
Thank you, sir. And I have shared the another link with Dr. Amala just now for ISAS that is working. So you can share that link with your group so they can get registered.
Okay, I'll do just that. Thank you.
Thank you very much. Thank you.
Thank you very much.
Bye-bye,
Thank you all.
It's
a pleasure.
Bye.
Thank you. Bye-bye.